Oh,
Paul, there was something about they said about talking to the patient. So what I find is that when you give mild sedation, like
yeah,
we give, and if you talk to the patient more often, a lot of the time in the UK, the nurses just chat with the
yeah.
patient. Oh, what do you do? What are you going to do today? Oh, and all that, and then just makes the patients more relaxed. I find makes it patient that distracts them from having a procedure. They think that everybody is chilled out, so it's not something a big deal, and then
No,
makes them more
I
relaxed.
absolutely agree. I think the biggest thing is that if you communicate with the patient, you get feedback. One, if there is a pause or a lag from in the conversation, why is that? Is that the person's focusing that? Am I doing something that's upsetting the patient? Is it a difficult question? But more importantly, am I causing them some discomfort? I steer clear from saying pain. I call it discomfort. So what you've got to do is look at if I'm causing that person pain, then I'm doing something wrong. If I'm causing the person discomfort, it might just be something associated with doing the procedure itself. So talking gives you a lot of information. Is there a pause? Is there an overemphasis? Are they breathing right? Are they taking a deep breath in before they actually answer? Is their answer very quick? You take on board if somebody was talking to you in a rush manner outside, what's up with them? You'd ask yourself, rather than if they're just taking the time answering the question. So it gives you a lot of information. Communication is not just verbal; it's non-verbal. And if you heard what was being said, what was quite rightly pointed out was that she was saying when the person talking to you, are they answering you? Are they able to answer you? You don't know what's causing that. Is the patient got the head in the pillow? Are they sounding muffled? The other thing is that patients cover up an awful lot of stuff, and they will grimace and they will, are you okay? Yeah, I'm fine. But the person looking at them will tell you more. Communicate. Try to get some honesty and communication. That also enables the patient then to feel that they can actually talk to you. They may see you at the moment as being somebody right up there, and I can't tell this person because I don't want to upset them. I don't want to insult them. They're doing something to me, and they could hurt me even more than what they're doing now if I was to say you're hurting me. So, in communicating with someone, you're actually forming a relationship. You're actually showing the person that you're a human being as well, and they can talk to you. And that's the biggest thing about it. So before I do any procedure, I always introduce myself. I always try to give them a big smile, tell them my name's Paul. I'm here, to help you as much. Please don't tell me if there's anything. How are you feeling? Anything. Just a couple of moments of spending with them. Then they'll talk to you. Then when you're just about to start the procedure, tell them I'm going to start the procedure, blah blah blah, and just continue. And then just continue in that vein. And I find that works an awful lot. And it's a great tool in your armory to actually help you be successful in what you're doing. Yeah, yeah. It causes a lot of tension. Yeah, I agree with you. And the other thing about communication, which we look at it when you actually do trainer, we talk about the communication from the trainee. So the trainee in this instance is the trainee trainer. So the person who's actually supervising you. Now, should your trainee, the one doing this, should you communicate with them and they don't answer you? Why is that? Are they overthink? Are they thinking? Are they concentrating? Are they what difficulty are they having? So often I will actually put my hand on your shoulder. That's what I'll tell you I'm going to do it before you do the procedure. I might touch you when you're doing the procedure. I'll touch your shoulder if that's okay with you. And that's to get your attention. Just stop what you're doing at the moment. What's happening? Explain to me what the difficulty is, etc. So these things help you, but it's also if you're communicating with the patient, they stop communicating with you. There is a reason why they stop communicating with you, and you want that communication all the time. So you actually try to show a friendly face, and it actually doesn't do you any harm when it actually looks at reputation as well. That person listened to me, so they go away. I had a little bit of difficulty, but when I talked to them, they listened to me, and so it's gaining a relationship, gaining trust, and it's gaining a reputation. So, welcome to the 17th hands-on. 17. And I've attended every one. We started out doing these courses. There was a small band of three who were the um, class of senior faculty, Dr. Saad Niaz, Vakar Ahmad, and myself. I was tagging along, trying to find out what was going on. So I'm not here to give you a history about the courses, but it was interesting then see the unit grow from a 1.5 room, 2 room, then to a 3 room on a ward to this massive state-of-the-art unit that's second to none, I would say, in the world. So when you actually look around what they offer in the form of quality of procedures, what they offer in the form of safety for the patients. So, and not just because the anaesthetic team were here earlier and still here, it's when you've got such quality service that you can, at the drop of a hand, have someone come in and support you. And it's not for OGDs and gastroscopies, ERCPs. This unit does fancy stuff. EUS, ERCPs, you know, spyglass. You know, there's so much that this unit does that many units in the UK would be envious of, many units in Europe, and they are not all based in the same centre. The skill that you've got here and access to is amazing, the skill level, but I still feel that in the world that there isn't the respect of what these this unit has accomplished and this type of unit has accomplished. You know, so if you were to quote your studies here in the US, they don't get the same amount of listening as what a study would do that came out from the UK. And that's just ignorance, really. And it's looking at how studies are done and the quality of it. The quality of work here is massive, and it is true what happens here, and it's a pleasure to be actually part of it. So what we want to do is talk to you about the issues of complications and consent. So what we've got is consent. I'm not going to bore a bunch of senior doctors about consent, but what is the most important thing to know about consent? I'm asking the candidate. Anybody? You're very quiet behind there. Hello. What's the importance of consent? So get them to sign. Okay. What's the importance of consent? Importance of consent? So we can tell them something, they'll repeat it back to us, and we think they understand what you're talking about. Right. How do you measure that? How do you measure the someone's comprehension, not just that they're repeating what you've said to them? How do you measure someone's understanding? Yeah. Okay, so let's look at colonoscopy. What are our risks of colonoscopy? Common risks of colonoscopy. Perforation. Well, he's covered. So we do with what I could turn around to you. The problems of war is death and total annihilation. But what does that actually mean? It doesn't mean anything. So let's. He said perforation, something specific. So you said over sedation. Okay, anything painful. So pain, bleeding. Yeah. Anything else? Infection? Anything else? Failure of procedure? And what's the most important thing about failure of procedure? Not knowing an answer, not being able to exclude something. That doesn't mean you're incompetent as a doctor, but it means that it sometimes happens. Anything else? Death? So in this country it may be different, but what's the risk of death? How many? What's low risk? But that doesn't tell me anything. What's low risk? So is it 1 in 2 chance of death? Is it a 1 in 5 chance of death? Okay. I've witnessed 2 deaths in colonoscopy. One before, as the patient sat on the table, they had a massive heart attack and died. Couldn't get them back. And the other one it was the last and futile attempt at trying to stop bleeding. But both go down as complications of that colonoscopy. So do you think that's fair? So a person was about to have a colonoscopy, they had a heart attack and died. That went down as a complication of endoscopy. Is it fair? Do you think it's right? You, as a colonoscopist, you were about to do a procedure on a patient. The patient is sat on the trolley. The patient arrests and dies. It goes against you as being that you have caused that patient's death. Cause of death, heart attack. But you've not touched them. Is it fair? No. I would say to you, the patients had bowel prep. Patients turned up. So you now have to start looking at what the procedures were that went in to see was it appropriate for this patient to have it. As it was, the patient had had a heart transplant 2 years earlier. The patient was highly anxious, and you could just see written all over their face that that person should not be in that room. The person wasn't. I was supervising someone, absolutely honest, and I hadn't seen the patient. The person I was supervising was another consultant from somewhere else, and they went and consented the patient. Come back and said they're a little bit nervous to come in the room, and I thought headlights rabbit. I don't know if you know what that means, but a rabbit will stand still if the headlights are on, and then you end up knocking them over. So headlights rabbit, and I said just pause what you're doing and stop what we're doing, and then within the next couple of seconds the patient eyes rolled, and then all hell broke loose. That was sad. But it went down as a complication against that colonoscopist, and it went to coroner. So you said one thing, very important, get the signature. What is the signature worth on a consent form? What is the signature? What's the purpose of the signature on a consent form? Yeah, you do sign them. Right. So what is the purpose of a signature from the patient and you on the consent form? What's the purpose of the signature? Okay. Do you all agree? I agree that you've just got them to sign a form. It's evidence of nothing. No, I would disagree. I would say to you that you've turned around and you say there is a risk of this procedure. The risk to you of this procedure of death is equivalent to walking out there and being knocked over by a bus as you cross the road. That's the risk to you. So that's a real risk. That's how you can measure risk. So when I ask you what's the chance of death, not 1 in 100,000, but it's the risk of actually being knocked over by a bus in Karachi. You can look up. I used to look them up, and I would then parallel them to something. The risk of having a car accident, the risk of dying in a plane, in comparison, and then say to the patient, it's the same risk as this, same risk as that, same risk as this, but you willingly do them. So that's how you do it. The signature part doesn't mean that the person has comprehended what you've said. All it means is that they've signed a form on your behalf. So what it needs to be, often to make it safe and secure, is witnessed. And they are actually starting to witness consents in the UK because of issues about legality and questions about things. Measure of comprehension. Asking someone to repeat something doesn't mean that the person understands it and understands what you're doing. So when taking the consent, it's actually looking at, on the whole, what that patient is able to tell you what they are worried about and what they want from the procedure. It's not about turning to them and then you bombarding them with information. So giving them information before, enabling them to digest it and come back and ask questions is important. So what they do in the UK is that they will have, and here, they'll send out information about the procedure. They'll also have the ability to telephone and talk to someone before they come back. And they'll also, when they turn up, they'll get a full explanation of the procedure and they'll go through the booklet and chat to the patient about any information that's in there that wasn't clear. So giving information before is important. So one of you mentioned perforation, one of you mentioned death, one of you mentioned oversedation. When a patient says, and you say to the patient, what are the risks? What are the risks? So what risk do you quote to a patient? If I said to you, what is the risk of death? What would you say? What is the risk of death from having a colonoscopy? That's you actually explain three. You explain the national statistics of the risk from death of this is 1 in 100,000. Our unit has never witnessed a death. I myself have never killed anybody or knowingly am aware that anyone's died from any procedures related like this that I have done. That's what you're supposed to say. But how many of us do it? We don't. We're supposed to. That's what we're supposed to, but we don't do it. We don't want to frighten the patient with too much, so we don't do it. But that's what we're supposed to. How would you feel about that? No, I'm on about how would you feel about the three statements that I've said? You have to tell them the national, you have to tell them the local, and you have to tell them yours. No, I mean, you have to tell them all three. You have to tell the patient all three. By law in the UK, you would have to tell them. Here, what are you quoting? Are you just quoting your local because there's a national statistic that you and data you don't know, you can't rely on because you don't know what's being released, and that's the problem. But there is a risk associated with it. So what you can say is that in Europe, the national risk of death from a procedure is one. Don't forget the type of procedure. Our unit has never had one. I myself have never witnessed one. And indirectly, even though you're giving that information, you're actually reassuring the patient. Withdrawal of consent. So, patient says stop. What do you do? Right. So patient's had sedation. The patient says stop. What do you do? Patient's had sedation. Has asked you to stop. What would you do? Counsel them. They've had sedation. Why do we tell patients who've had sedation they're not to drive and not to sign any legal documents for 24 hours? So, but a patient who we've told shouldn't drive and shouldn't sign any legal documents for 24 hours, can they make a rational decision for themselves? Does that give you the right to act in what you could class as their best interest and continue? I'm playing devil's advocate here. I'm asking you, what would you do? Patient says stop. They've had sedation. What would you do? Okay. Procedure, the proper procedure would be stop. Are you sure you would like me to stop? Yes, I want you to stop. Why do you want me to stop? Blah, blah, blah. Exchange. Get somebody else in that's senior. Could be the senior tech. To the doctor. Not a problem. Patient wants me to stop. Are you sure you want them to stop? Explain to them that they're having you to stop. And when you stopped and the patient's gone out and had a sleep, why didn't you continue it? I didn't continue it because you asked me to stop. Oh, well, I'm happy now. You can continue. I don't want you to go back in. I can't go back in because this is a conversation that happens. I've had it witnessed, and another person has asked you, a senior person has asked you, as well as myself, and clarified with you that you asked us to stop. So if you've got a patient who's had sedation, don't just go on them telling you to stop or asking you to stop. Withdrawal of consent can be several ways. It can be actually they're asking you to stop, or they move their body away from you. They put the hand to the back. They do all these things. I've seen people hold people's hand and pull it forward, thinking that they're trying to grab the scope, and it's did did it's asking you to stop, but they just didn't say stop. So you've got to take on board what's happening. So withdrawal consent can present itself in many ways, but the procedure, you need to get it witnessed. Withdrawal consent can be at any point in time. The biggest thing about consent, what a lot of people don't do, is get a consent form signed and witnessed when the person comes in. So the patient has seen you outside, right? They sign the consent form. When a patient comes into the room, what happens? Patient is laid down, sorted out, made comfortable, exposed, gets sedation, blah, blah, blah. What should happen is the patient comes in and sits down, and before anything else happens, you ask them, hello, you've come today for this. Are you still happy to proceed? Yes. And then you countersign the consent form. That's what should happen. How many do it? And that's what you should, that's the best practice. That's what you should be doing. Any questions? You're very quiet. I've made consent sound serious. So there's many benefits of consent. What is the benefit? We didn't actually say why we get consent, and it's actually say what the benefits of the procedure are to patients. Test their understanding. You can test their understanding. That's what you were trying to tell me. But what they need to do is that you need to know how to actually test their understanding. Getting them just to repeat it back to you is not. He quite rightly turned around and said, you get them to turn back and you will question them about what their understanding is and that how to go about it. Retention of information. I tend to say something to a patient which is slightly memorable and then ask them a few more questions and then I'll say, oh, by the way, do you remember what I said about, and then if they say, yeah, blah, 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 I know they've retained the information and that they've had some comprehension. So it's just a technique of just going back and looking at what they need to do. The Mental Capacity Act, that's where you alluded to, and over there you alluded to. It's the Mental Capacity Act that affects the UK. Don't know about Pakistan, but you can act in the best interest of a patient with regards to that. But also the Mental Capacity Act is the person able to make a rational decision for themselves? And if it's dealt and felt that the person can't, you as a clinician can act in their best interest. But then you need to carry out that procedure in a manner that enables you not to torture the individual, but to actually accomplish. And being in a unit like this, that would be a lot easier to accomplish. Right. I understand culture, and I found it difficult at first, back in 2012, when I first come to understand about consent and family members and the husband making decisions with regards to the wife and his mother and all these type of things. At the end of the day, cultural differences need to be understood and respected. And if that's the case, then that's how it is. And the family have adopted that rule as well. And if the family's adopted that way of behaviour, then that is acceptable. I don't frown upon it. I still would like to actually turn to the person concerned and talk to the person concerned and say to the relatives, what's your opinion? And but pay the person respect and still talk to the patient who it's happening to and still involve them. But if the relatives are saying, she's saying no, but it's in her best interest, I'll talk to her, let them talk to her, and then take it back on board. But family members in this culture, it's very important. In the UK, don't listen to anything except if it's a child. However, child in the UK has not got a cut-off age. It's got an age where they're, again, you're looking at capacity, that they can make a decision for themselves, and that is deemed to be about 11 and 12. So an 11 and 12-year-old can delay their significant treatment, and that is not uncommon in the UK. 11 and 12-year-old can say, no, I don't want cancer treatment, and despite what the parents say, I want to take it to court and take doctors to court and sue them and say, you're going to treat my child. There's nothing they can do. The child is Gillick competent, as they say, and that's it. But here you need to actually focus on what the family's needs are as well, which I fully respect and understand. So there's an acronym that you need to do. Explanation. So this thing, embrace. Explanation, motive behind the reason for having the test, rectal bleeding, you know, loose motions, things like that. Benefits, to exclude anything significant. Risks, there is a risk of bleeding, perforation. What perforation means? So we said perforation. What does perforation means? Means that you could have a hole in your bowel. It could mean that you'd have a bag permanently or temporarily put on the side of your abdomen. These are the things that we find uncomfortable to talk about, but these are the things you need to actually mention. Alternatives. Can you do it any other way? Well, what's in the best interest? A young person, a young lady in particular, you don't want to expose them to radiation, necessary. Complications, issues that arise as you go along and how to deal with them. And side effects. There are side effects associated with the procedure. What is the side effect of colonoscopy? So we're thinking about colonoscopy. The biggest thing where side effects are is what we use to do the procedure. Yep. This we forget about bowel prep and the side effects of the bowel prep, and that's the thing as well. When you provisionally consenting a patient, you should consent them separately for the bowel prep. Bowel prep can kill a patient, so we remain ignorant about what bowel prep can do. So bowel prep can kill a patient. Side effects associated with using CO2, and the person may have issues with regards to CO2 breathing regulation as well. So you've got to be aware of that. So should I be using that or should I be using air? Yeah, absolutely. Yep, yep. The big thing here is the last meal before they come for colonoscopy, or they think it's going to be their last meal, so they have a big meal and that before that cracks me up. Uh, but I think culturally, you will have worse bowel preps. I've found here the bowel preps are not as good as what you get in the UK. Sad to say. And maybe that's due to the fact that over there is a dedicated team now with a lot attached to every unit that will actually talk to the patient, ring the patient, talk them through the bowel prep and any issues associated with the bowel prep. So it's incredible what a lot of units are going to. So that's the Embrace acronym that I went through. Risk relevant death. So we're actually looking at it's 1 in 1,500 for death. That's a national issue. One in, it says 900, but let's call it 1,000. But that's for diagnostic colonoscopy, and therapeutic is half that value. I think that it speaks for itself that therapeutic will have a higher risk of perforation. But 1 in 1,000 for diagnostic, that's all endoscopies. That's including bowel cancer screening. So that risk is quite high, really. Risk is high with EMR. Well, that speaks for itself. The risk of what other risks have we got? We've talked about bleeding. What can we do? Interventions. We mustn't be frightened of using certain tools. So grabbing a bleeding vessel with a pair of forceps, and that's when this. What happens is there's a lot of anxiety when you see something happening, and you see slowly some blood appearing, and you see this vessel releasing this red solution that you're wondering, oh my God, can I stop it in time? And it looks a lot more than what it actually is. And then you get down the forceps, you say open, and you say close, and they'll open and they'll close very quickly. Forceps have got a very sharp teeth on them, as in it's a very sharp device. So if you say open and then you say slowly close, you can actually control how it closes. Stop, and then they stop, how it acts on the vessel. So it's important to take control. So what you want is them to actually stem the bleeding. What you also want is them to do it slowly. So what you want and how you want it. The most important thing to put first is how you want it. What I want is the forceps to grab the vessel, but how I want it to grab the vessel is slowly so I have control. NSAIDs will increase your risk of bleeding. So withdrawal of consent, entitled to refuse at any time, treatments. Unsedated patients, you can withdraw consent straight away. Sedated patient, endoscopy acts in the patient's best interest. There have been several cases where doctors in the UK have continued. It's gone to the GMC. Patients have been lost their cases on the most part. Some haven't. But what it is that it will go to the GMC if a patient feels that you've acted inappropriately when they've asked you to stop. Also, there's been 2 incidences where procedures have gone to the GMC, I don't know why, where patients have said stop, gone into recovery, and then said, oh, well, I was sedated. And you said to me before we did the test, what I was saying to you was that we asked you not to sign any legal documents or drive for 24 hours because I'm not capable to make a decision for myself. And you should have acted in my best interest and continued. So whatever way you do, you can't win. That's why then it's best to actually consider getting a second person to come chat to the patient and getting their signature to back you up as well. And it can avoid all that rubbish. Read the notes. I've seen it where someone's gone in, sat down, read the wrong set of notes, started talking to a patient. And then the patient looks a bit confused. So read the notes, be familiar with the history, make sure it's the right person. So be familiar with the local forms. We'll use a form here, might not be similar to what you use, but have a look at it and understand it, the local form that's used. Always check for understanding and always allow time for the patient to ask questions. Don't look like you want to get out the door, look at your phone, look at your watch, and that you're desperate to get out the door. Right, we're there to questions. Forget to keep an eye on how long the consent process takes. You don't want it to continue too long, but you don't want it to continue and just be a quick thing. You want it to actually be enough time that the person has understood. 5 minutes, 8 minutes is probably about the right time, but if you're going on for so long, it's too much information and you cause issues. Indications for colonoscopy: bleeding, iron deficiency anemia, strange anomalies on scans, assessment of colitis and Crohn's. What the important thing is that we're seeing a drop in age where our barrier to access to colonoscopy is being lowered. I think what we need to do is look at that, and in the UK especially start to lower it a little bit more. At the moment, bowel cancer screening is offered to 60. It will be offered in the future to 55, then hopefully 50. The services are not there to provide that at the moment. That's why they ration it by picking a certain age group and going forward. Here, your tolerance and your access to colonoscopy is quite flexible. And that's what's important. You're using your intelligence and you're able to make an assessment and judgment for yourself. You're not following rigid guidelines that are set down by a tertiary committee who are saying, if the nice guidelines are saying this is what the criteria they need to meet to actually have access to it. You're a consultant, make a decision. The UK, you get lambasted. Bowel cancer screening, family history are important reasons for doing surveillance, as well with IBD, acromegalia, 40 years of age, and previous polyp cancers, etc. So contraindications: withdrawal of consent by competent patient, endoscopist not accredited, incompetent to perform the procedure, uncooperative patient, oh my word, unable to be safely sedated. So contraindications: withdrawal of consent by competent patient. So this is meant, it's a bit of a twister. Contraindications, it's looking at what we shouldn't be doing. We shouldn't continue with a patient who is fully competent. Do it. An endoscopist shouldn't be allowed to perform procedures if they're not accredited. Wonderful thing about this course that you're on, this is looking at it's not an accreditation course, but it's looking at your skills and being able to give you the ability to make an assessments for yourselves, and also give you access to a portfolio where you can monitor your progress. At the moment, we've looked on here and I've done 25 to 30. I've done around 100. I've done around 250. I've done around. So whereas keeping an accurate log will enable you to understand, I've done 180. In those 180, I've given this amount of sedation. In those 180, I've found this, and this. And then you're able to extrapolate the data. So anybody then turns to you in the future and says, have you got any evidence? You've now got an evidence log. And that is live on this unit. You can do that and you can access it. So your risk to the patient, if you continue with a colonoscopy, if they've got active severe colitis, megacolon, 10 centimetre or more is what you look at. If their right side of the colon is dilated by approximately 8 centimetres, you put in a little bit of air in there, you're going to have a massive perforation. Acute diverticulitis, very easily perforated because you can find yourself going down a track and into a hollow that you don't know. You're not really completely exposed to that yet. But in the next 10, 15 years, I'd say that Pakistan will have a significant episode of diverticular disease because of cultural travel, etc., and our Western diet will slowly infiltrate into here. Lower bowel GI endoscopy are relative to be considered current clinical situation. So you should be fluid in what you're doing. Patient who comes, they've had an issue. You should be fluid and able to make a decision. It's not appropriate to do this procedure today. But I've had my bowel prep. I don't care. It's inappropriate to do this procedure today. And these are the reasons why. Bowel prep is the biggest thing that we overlook and we're very ignorant about. We think it's just something, go take it. It's just like taking 2 aspirin. It's not. It's a bush journey, but it's a bush journey across a very rough ground for some people. and then you still have to consider what the risks are to the patient. Bleeding, you can actually get bad bleeding from the bowel preparation itself. So I'm not going to go through all that. Mispathology, there's a big risk of mispathology. So if you actually look where high incidence of polyps, the highest incidence of polyps is in the sigmoid in a lot of areas and the descending colon. That's where the majority of cancers are in the UK. But in Pakistan, the incidence of rectal cancer here is quite high. You know, my experience of rectal cancer is low compared to what's here compared to what's found in the UK. I think the biggest thing for helping prevent complications is proper and thorough skill development. I don't like the word training. Why don't I like the word training? Any idea why I don't like to say I trained you? Why do you think I would not say I trained you to do colonoscopy? Why would I not say it? Why do I think it's wrong to say I trained you? Would you like? Do you like it? Give them thought of what training is. So I'm going to say to you in a slightly different way then. Are you a dog? You are a dog. No, are you a dog? No. You train a dog. No, you train a dog. Dog to sit, dog to roll over, dog to stand, dog to fetch. I don't train doctors. I coach. What's the difference between coach and teach and train? Sorry. What's the difference between coach and train? The reason why I'm bringing this up now is because you've all gone very quiet, and I'm probably boring you with this rubbish. But the reason why I bring it up is probably I'm boring you. Now the issue is that you coach, you take on board that you have already got a modicum to a significant degree of experience, and that you're capable of doing various things. I, as somebody who is, an expert in that area, is able to look at you, like Chanel is able to look at you. You're going to go there and ask him. He's going to look at you. Novel's going to look at you. They're going to see what you need to do to actually improve. And what they're going to do is then point you in the right direction. They've already taken on board that you have got skills necessary, but they just need honing. So that's why we coach you. Don't train you, because if I trained you, it's like saying, do it this way, and that's the only way. Whereas when we coach you, we look at what you do as an individual, and we look at how that individual skill, how that individual ability can actually be encouraged to follow a path that might make you better than what you are doing now. That's the difference between coaching and training. And what we need you to do is think about what this course is about. This course is a short course, but it's about you own it, and it's about you asking questions. So don't just sit there and be bored. Come on, ask questions. I'm going to flick through a lot of these slides, but ask questions. And it's important. Otherwise, you'll find that there's disengagement, not just from your side, from our side. So from my side. So you need to actually encourage yourself to actually say, I'm involved. Might be language barrier. I understand that. But the biggest, most important thing is you are here on a course that you own. You're here on a course to get the best out of it that you can. You need to actually understand what is being said and done. And the often thing is that what did we cover with consent? What we covered with consent is I've given you information, and then you sat there quietly. I could have said to you, right, that's consent done. Happy, and you'd have gone, yep. But did you understand, or were you thoroughly cognizant with the information that was being given? Not necessarily, not to my satisfaction. So what that meant was I didn't give you a proper experience. So indirectly, I didn't do a proper consent procedure. So what I'm saying, look at what is happening and then be fluid about what is happening. That's why I've just done what I've done. So take ownership of the course. Sedation is a big risk to patients, as we know, and we've had that discussion today already. I'm not going to talk about the individual pharmacology at all whatsoever about it. I'm not going to talk about appropriate sedation. You've already said what you give. However, anybody who's giving 4 milligrams, I think you need to look at what you're doing because that's a high dose to start off with in every case. You need to actually have, like Shanil was saying, the antidotes. If you do use the antidotes, you have to then think about, was that something I could have avoided? Well, definitely if you've started off with 4 milligrams and someone starts to snore, indirectly what you've done then is that you've entered into the realm where they need the antidote. And so you would actually then call that a near miss in the UK, and that would actually be reported to the central office. Yeah, yeah. Yeah. On top of that, I thoroughly support that. On top of that, what happens is that people will give, say, 2 milligrams, and they'll give it as a bolus, very quick. Give it. What that does then, the argument is that it reaches its peak very quickly, and then has a big effect initially, and drops off half-life very quickly. Whereas you're supposed to titrate it, and it takes longer to reach that point, and then the half-life is longer. But you actually are giving more, is what they're saying. But I thoroughly agree, you have to wait. Both techniques, you've got less control over the one that you give as a bolus. That's why that's frowned upon. Whereas the one where you're giving it as a titration, you can see how things are changing with the patient as you give the medication. Yeah. So I think the big thing to do, right? What is the, I've always had this debate. What is the benefit to you, to one of us going in there and then doing a colonoscopy in front of you? What's the benefit to you to seeing myself or Novel, Shanil, Prof Mansour, Asim doing a procedure in front of you? What would be more beneficial to you? Would it be more beneficial to you to start, do procedures, and then work with the faculty? I've always been unsure about the benefit to any course that I've done, UK and here, about demonstrating colonoscopy because it shows you what could be done, and then you come and you go, well, I might not be able to do that. I might, and it then can, create a false scenario. What will happen? What I think is good, but correct me if I'm wrong. I think what's is good is for you to do the procedures as we go along, get hands-on, start practicing hands-on straight away. One of us to be here to actually talk about what's happening in the room. One of us to be with the mannequin so you can do things with the mannequin. But while you're doing the procedures, you need to understand that we will step in, we will take over if you're finding it difficult. That's then when you'll see how we demonstrate things. That's then when you'll see we will probably pass the scope to a point where we think you've competent taking it over or retaking it over. It might be that you're not understanding something, but what you will do is be able to, you'll be talked through live with the patient. rather than one of us going up there saying, right, you'll do that, and you won't notice what the hands are doing, you won't notice what the fingers are doing. So it's your choice. Yeah. Because you in your folders you've got an assessment form that will be done when you do every colonoscopy. Can you just open it up? So that form will then, between you and the trainer who's with you, they'll go through the form and you can see it split into sections. And in those sections, it will say whether you're competent, adequate, all these type of stuff. Can you see it? Now, at the end of that discussion, that'll be taking place just before, because you have to look at what sedation, etc. So there's some bits that are covered by the trainer that's in that form before you even see the patient, consent, all that type of stuff, because we'll still ask you to look at a few things. But then the next thing, what we're looking at is it goes on to talk about talk steering, it goes on to talk about, whether you resolve various things. So at the end, there is a bit for a section where the person who's been supporting you on that procedure will then say, on your next procedure, look at where your hands should be. Look at what your stance. Look at how your talk is being applied. Think about when you're in the sigmoid. So they'll be very specific. So when you come out of there, you can come back, and then there's a mannequin. There'll be one of us who's with the mannequin, and you can say, "He said this to me," or "She said this to me," and then we can go through and replay what you've done on the mannequin when it's safe. But what I'm saying is to you, one of us can go and do a procedure, no issue, and do that. Would that be a benefit to you, or would it be far beneficial to you to be start off doing the procedures and then doing what we're saying? It's your course. Which, yeah, it might be that today you've done this, and then you say, "Look, there's been too much going on. Can we?" So, yeah,
You have on your computer. We made this online website, which is free of cost. All you have to do is register on it, and it has all the docs for everything. You email IRCP, and you sign it off. So any case that you're doing, you can just put it on there and make a long as to how you get done. And the trainer, whichever trainer you are visiting, can sign you off for documents. It's still used for you observe it, fecal intubation rate, TI intubation, polyps. So these are just like drop-down menus where you can just put on, and then you just submit it, and then it just gives you a log. So, like for example, I think we have so some people have 16 procedures have been uploaded, which have been uploaded. So it just gives you a sort of a logbook. So in the future, say for example, somebody wants to know how many cases have you done? Like we said, how many cases have you done? Some people said 100, some people said 250. What's the evidence? You are saying you've done 250. How have you done 250? Okay, so at least you have a log book, and it also lets you get you signed off by your trainer. You can say, look, I've been signed off, and I think in the future the aim is to make that accreditation stuff so that we can accredit, give you a certificate to say that you've done so many jobs and signed off for Colonoscopy. So it's just one of the things because you've got already got a form there. So it's one of the things that you can use when you go back to your unit.
the biggest thing that people fall down on when they apply for jobs in Europe, UK, is providing evidence of past experience. So when somebody says they've done 500 colons, I can't take your word for it. So I've got to, I've, you apply for the job, I cannot take the word that you've done 500 colons. I need you to show me the evidence you've done it. And people in Pakistan are in the same predicament as what you are. You haven't got any real evidence. This gives you real evidence. So if your intention was to go work somewhere abroad, this gives you real evidence.
So,
Demonstration. Am I leaving this?